on your digital display. I think most of you know this, but I'm not so sure. The head are gold cups, and we put paste in those. And I'm old enough to remember that, you know, the EEG labs used to use stinky collodion, and it smelled bad. It would make the kids cry. And then there was this drying gun that made a ton of noise that would scare the kids. Anyway, we don't do that anymore. We use paste, but for any kids who've had an overnight EEG, like in the inpatient unit, they do the stinky collodion and the gel and the noisy gun. They don't do paste like what we do. And then just for efficiency, we've ended up using the snap wires, and these work pretty well. You can use them for eyes and ECG and EMG. They got really foamy sticky pads, so they're hard if somebody's got a lot of hair on their chest or a beard, you know, it's hard to put these on. But these are these self-sticking snap are that have their own gel in them, are things that we use for the non-EEG stuff. I think you guys already know this. Hopefully, you know, one is up and one is down, and that gives you a certain look to your EEG. Things have changed. The newest version, these are all referred to M2, and the only thing a little different about infants is that you use a half a centimeter. I like to have the video on when I look at sleep studies, and I like to see where the techs put the chin stuff. And I will tell you that there is drift that goes on. And so it's always a good idea to have the video on, because I've seen chin EMGs be in all kinds of wild places, and then you wonder what's wrong. I think that sometimes a little drift goes on where they say, oh, you can put it on the masseter muscle. You don't need to do the tongue muscle. But that's not really where it's supposed to go. So know where it's supposed to be. And, you know, for those of you who are directors of labs, watch out for drift, because I have seen these ones that go under your tongue or strap muscles go and end up on the cheeks. Legs, hard to get the impedances down, so you don't want to be too rough on your staff about that. In the olden days, people used to put motion sensors on, and because they were easier than doing the EMGs, but the official party line is these need to be EMGs. Okay, so here's our first fun question, and I can't see all you guys, so are you guys unmuted and you can talk?
Yeah, we can talk. Yeah.
Okay, all right. So I think probably the best way is just shout out. Scoring of PLMs is based on what? Arm or leg movement, flexion of the great toe, leg movement, or EMG of leg muscles? Anybody?
D.
Very good. But if you've ever been in a lab where people are confused or use non-standard sensors, you might have picked something else. I think you guys all know what a montage is. It's just a sort of a system. And sometimes there's a little bit about technology on your boards, about input 1 is subtracted from input 2. And whenever they're the same, it's not amplified. That concept may show up as a board question. I think you guys are aware that you only need kind of one side, but it's nice to have two sides if there's some asymmetry, or particularly for kids, you've got a backup. But officially, you could read with just what's on here. Pretty cute. Impedance. There will probably be some question about impedance. It's a measure of the contact of the skin. The techs will be checking that, and there's often a question about what number should the impedances be for EEG and EOG. So that could be a money slide. Okay, and if your impedance is bad, this is what you get. Everybody see which one doesn't look so good? That's what it looks like when it falls off. There is an expectation that you know a little bit. I mean, I was raised in the days of the analog signals, but now things are digital. And so you can see that in this 1 second, I'm going to use my cursor. If you only sampled at 0.2, this will give you a sense about why sampling rate is important. You sample, and for this thing, it's a -7 microvolts. But right here, this waveform has a 44 negative. And right here, it's back to 18. And here, it's a positive 60. And here, it's almost at 0. But so that's where the sampling rate is very important to produce a digital signal. And you can see what would happen if you only sampled at 5 times per second. And see how beautiful this waveform looks like. But if you only had a sampling rate of 5, it would look, you wouldn't have much fidelity. And here you can see sampling at 5 and 10 and 20, and even 20 is not enough. But and I showed you the summary slide, but you can see how important sampling rates are in terms of the fidelity of your signal. And there's 250, and it's a nice reproduction. So the digital accuracy and, you know, being able to use your eyes is going to depend on the amplitude and the sampling rate. And so you may get a question about if you change the digital resolution. So here is a picture of sampling alpha at 200 samples per second, and you can actually count the frequency. I'm hoping that at this point, before you leave us, you have some sense of frequencies. What are delta frequencies? What are theta frequencies? What are alpha? What are beta? Spindles? What muscle looks like? And 60 hertz, that could be some kind of electrical interference. Just a little comment about filters. The more you filter, the less you see. Very good sort of way to think about it. And you should only, this is kind of more for your text, only do filter settings when you've tried and failed to fix the underlying problem. There are 3 filter types. Low frequency. These are sometimes called high-pass filters. So they pass out the higher frequencies, and they're sometimes called time-constant filters. The high-frequency filters let the low signals pass. And then there's that notch filter, which for Sally, I was just going to mention, that's often on in our system, and that's something you and Subra may want to talk about, because usually those aren't supposed to be on unless, you know, you should have tried to get rid of electrical interference. And it could be just the place we have our stuff and the electrical beds, maybe they always have to be on, but that might be something to investigate, because in the olden days, you were supposed to fix things and not turn the 60 hertz filter on, and it seems like it's always on in our montage. There will be one question about high frequency filters. And there's a low pass, it's called a low pass filter because it lets in the low frequencies. So can everybody sort of see that as you're going up in your frequencies, you're filtering out those higher ones, but you're letting the low ones pass? So keep that in mind. And but the pass out, but the filtering out of the high frequencies, it doesn't filter out all of them. There's sort of a decrement in what it filters out. So here's an example of a slow wave. And what happens as you increase the low frequency filters? See those beautiful slow waves? But if you turn up the low frequency filter, you totally lose it. And every once in a while, somebody's pushing buttons in the lab and you can't see anything. So there probably is going to be one board question about when you increase low frequency filters, what happens to slow waves? As the low frequency filters are increased, slow wave activity disappears. This is a money slide. And you can see it disappearing. Everybody good with that?
Yep.
But flow is a slow signal. But look what happens to your, like this could be your thermistor when it's set wrong. So this is a typical high frequency filter for a flow signal. But look what happens when somebody chooses the wrong filter. Increasing the low frequency filter reduces the amplitude of the respiratory signals. Key concept could show up on your boards. Okay. Why would you increase low frequency filters? Get rid of 60 cycle noise, decrease the amplitude of the fast frequencies, decrease the amplitude of the low frequency activity and causes waveform distribution, decreases the sampling rate. So increasing the low filter frequency, what's the correct answer here? Based on the signals we just looked at? Anybody? This is a standard board question. Increasing the low frequency filter will decrease the amplitude of any low frequency activity and cause waveform. And we just saw that with we saw it with delta waves and we saw it with the airflow. And those are both sort of low frequency activity. Something like this will show up on your boards. What happens if you change the high frequency filter? So these are the standard filters for chin, but what if you started to turn down the high frequency filter? You lose all that fast activity because you've filtered it out and you don't get a good picture of the signal. So as high frequency filters are reduced, you lose EMG activity. This is a money slide, and something like this could show up your board. So it's something like this on the IS or on your temporary exam, your intermittent exam. What's the name of that exam?
The ISRs?
Not your ISR. Yeah, your training.
In training.
In training. So is what I'm showing you, were there questions like this?
I actually don't remember seeing particular snippets from these channels.
Maybe they were just text?
Yeah,
do you remember anything like this?
Text form.
Sometimes I think it helps to see the visual, because then you can picture, you know, because you know the filter, what it's supposed to be right, and then you can imagine this high frequency filter turning it down, and you filtered out all those higher frequencies. I think this is a nice visual. Okay, so this is kind of a summary slide. Filters attenuate known percentages. So if let's say you had a 70 hertz wave and it had an amplitude of 100 microvolts, that would be a good description of an EEG spike. And EEGs are actually, they're high frequency filters in the EEG lab are actually on 70. We put ours on 35, but they will attenuate the wave's amplitude. So it's not going to be as high. Are you seeing those little messages I'm getting? Is that fixed? Is that showing up on your thing, or is it just showing up on my screen?
I'm seeing.
We see them.
It disappears.
They do, all right. I don't know how to turn them off. I think there's probably a setting to turn them off. Anyway, so these two concepts, what happens to a fast wave or a slow wave as you apply different filters, I promise you those will be on your board exam. So here's an example. Here's a nice, slow delta wave, big one, with a low frequency filter of 0.3. But then a tech turned it to 1. Why would a tech go from 0.3 to 1 for the low frequency filter? What's a common reason they do that? Sweat artifact, because that's a slow thing. So they'll go from 0.3 to 1. They shouldn't do it permanently. They should just do it as they're looking at it. But if you put what they typically do is to get rid of sweat, and sometimes you do that when you're reading. You go from the low frequency filter of 0.3, and you want to filter out the sweat activity, so, just for your pattern recognition. But look what happens to your waveform. You'll lose amplitude. I kind of want you to be familiar with that concept. You might still recognize that as a slow wave, but you've definitely dropped the amplitude. So what if somebody has myoclonus?
Rosen, quick question.
Yeah.
When we filter out these these frequencies, why are we seeing a lower amplitude of things? Shouldn't the amplitude of the frequencies that we're interested to be at the same amount?
No, they do distort the waveform.
Okay.
And that's just sort of a little, maybe that may not be the biggest thing they ask you about. They may just want to know that those things disappear, but they do distort the waveform. So here's an example of myoclonus and what it looks like. So what are our typical EMG settings, everybody? They're set. What's our low frequency filter and our high frequency filter for EMG? This should be on the tip of your tongue.
10 and 100?
10 and 70.
Oh, 70.
Well, it is 100, but sometimes it's 70 for just, it's a little fluke of our system.
Okay.
So there you see the amplitudes, but if somebody made a mistake and put it on and I've seen this, sometimes the sample type is wrong, and if they put an EEG sample type on an EMG, I mean, I guess you'd still recognize it. But you can see when you go down to 15 for your high frequency filter, you filtered out all those, and the movement lost over 66% of its original height. I think this is a nice visual of what happens when you change those filters. There's something called a notch filter. That's what Sally and I were just talking about. And that seems to always be on in our system. And that's just to filter out that 60 hertz activity. Boy, I wish I knew how to turn that off. And then these are sort of pictures of how those high frequency filters work and what things they're taking out. The 70, the 50, the 35. You can see it doesn't completely take them out, but it takes out a certain percentage of it. Okay, so
if you close out your Outlook, they should not be appearing.
Oh.
Yeah.
Let's see if I can do that.
And just close all windows. Okay.
Okay, I did it. Okay. Okay. This next set of slides are something I put together for our staff, but I just wanted to share them with you because as the years went on, there were like 6 things that made me crazy. And so I just want to share them with you as if you were a director of a lab. What do you do if the signal's bad? Fix it. Don't filter it. Don't change the scale to make it look small. That was something that they would do. You know, a signal looked really bad, they just turn it off or turn the scale down. But not that. And this was a chronic problem because one of the montages had a bad thing, had the wrong filter settings, and the staff would never recognize it. So here's our correct. That's my dentist calling, sorry. I have an appointment later today. Okay, these are the correct respiratory filter settings. And we used to have this problem. Somebody would be pushing buttons and they would change the low frequency. And remember, this is a slow signal. And look what happened to the airflow. Here it is. And then it would look like this. Huge change. But because it's a slow signal, if you change the high frequency filter, it doesn't change it very much. So I just wanted to show you a slow signal, a respiratory signal, the correct settings, and what happens if you mess, and this was happening a lot until I got the staff to kind of pay attention to the filters. And then this is the high frequency filter, it doesn't change it so much. You can still read it. So these are some of my favorite things that help me spot clinical and technical problems. And I hope that our staff will do these things and that wherever you go, you think about doing them because they make you a better interpreter of sleep studies. And this is put on a grid on this primary snoring channel, which makes it easier to identify the height of different waves. I like the CO2 grid. That's how I found out there were calibration problems, not just waveforms. Paying attention to respiratory rate, knowing whether you had a good SpO2 signal, knowing the difference between the heart rate that came from the pulse wave versus the ECG, and putting a grid on PAP and showing leak. Those are things that I tried to get the staff to do here. And so this is the PAP grid, and then you could see where, if it was actually delivering the pressure that you wanted. So if you didn't have a good flow signal, maybe the pressure wasn't really being delivered. That's still an ongoing project to get them to display that. I always like to display the respiratory rate. Everybody see it here? I think we're good with that. But here's somebody that's tachypnic. The most common reason might be obesity, but or chronic lung disease. But I think that is part of your interpretation. Does everybody see this here? It's always been a problem to get the staff to display the pleth waveform or to actually look at it. But look what happens when you don't have a good pleth. Look at those values. Those aren't real. That's just a bad waveform. And then you can start to see it come back a little bit, but it's variable. But here's the same patient when they got the signal on good. That's why I like to see the pleth waveform. See how the values are nice? And then the CO2. Boy, this went on for a long time until they realized they had the calibration set wrong. But you know, it looks like you have a good waveform, but the numbers were wrong. And remember, we have a different thing for the cap versus the CO2 number. But that's why I like the grid, because then I could tell if they had the equipment set up right. How are we doing? We're doing okay. So there are physiologic transducers that take physiologic signals and convert them to electrical signals, and these are the kinds of sensors that are used for snoring, airflow, respiratory, and oxygen saturation. These are all straight out of the manual, so I'm not going to spend much time about those. Most people do not use esophageal manometry to measure chest efforts because you have to stick something in somebody's nose. And nobody likes to do that, and our staff doesn't do that. And it makes this, it just makes it impossible to have kids. Most RIPs are not actually calibrated. Most of us do uncalibrated RIP. And know that piezo belts without the pressure sense are not really acceptable for ASM accredited labs. Snoring, we've got all different kinds of snoring. Some are vibratory, some are auditory, some come from the nasal pressure signal. And there could be a question about pulse oximetry. What's the physiology behind that measurement? And CO2, because it is a pediatric requirement, just know that you need a little clinical judgment here. If the numbers don't make any sense, there's probably some calibration problem with the equipment. So, and most people, although you could do arterial measurements during a study, nobody does that because that's very invasive. And know the difference between EtCO2, which is measuring molecules of CO2, versus tissue samples of CO2 from your blood vessels. Okay, this is a duplicate, so we're going to skip this. I just didn't delete it. Okay, so I put in some quiz questions that I thought we'd have some fun with. So everybody unmute. And we're going to skip this one. Okay. Which signals are necessary for scoring sleep? Anybody?
A.
Which one?
EEGS, as in apple.
Yay! That's right, because you don't need the legs and you don't need the ECG for just scoring sleep. The essentials are those, and I have to fix that one slide. The standard filter settings for sleep EEGs are?
C as in Cavaliers.
Very good. Let me go back for a second. What's the right, D is the right answer for what question?
Like your abdominal belt.
For respiratory signals, yeah.
Yeah.
Abdominal and airflow, those are the right signals. Okay. All right, here's a trick question. Which waveform has the fastest frequency?
Probably muscle artifact.
Muscle artifact. Muscle artifact.
Very good. Is everybody good with that one?
Yeah.
Okay. I made that one up myself last night.
Clever.
Okay. What will be the pen deflection if the sensitivity is 10 microvolts per sonometer and the input voltage is 75 microvolts? You have to do math for this one.
75 millimeter.
Okay. Was there something like this on your in-service exam?
I
don't think so.
Okay. All right. Good to know. Okay. I had some more things. We can look at them and just see if these are things. I'm hoping at this point you know these. So my goals here are that you can recognize alpha, you can recognize low amplitude, vertex, K, spindles, you can count slow waves and see eye movements. So here we go. So in terms of describing waveforms, you need to be able to describe the amplitude, the frequency, the shape, and the distribution. Was there something about this maybe on your in-service exam? Any of this look like there were questions? Does anybody remember something? Yes, no?
I don't recall.
No.
Okay, all right, that's good. Everybody good with this one? Like if you had to say what was the amplitude here, what was the frequency, what was, I mean, you'd have to probably know the voltage, but you could describe this?
Yeah.
Because I can imagine there'll be a board question saying, where do you find algorithms and some description and their shape and their amplitude? Is this too basic for you guys, or is this an okay review?
This is a good review.
And this, I could imagine a board question that would look something like this. You can see the alpha that's most prominent in the occipital, and you can see it melting away in the frequency change. And you can see the EMG drop down. At this point in your year, this should be like, this is somebody falling asleep. Everybody good with this?
Yes.
Yep.
And that concept that as you go from waking to sleep, your alpha, you lose about 2 hertz. Everybody kind of aware of that? And everybody know that abbreviation, LAMF, low amplitude mixed frequency. That's typically used to describe sleep. I think in this particular example, I would have had the gain up a little bit higher so that you wouldn't be confused that you're awake, that you're waking. And this concept, this is one of the underlying concepts of doing biocals. So what happens in biocals? What instructions do they give to the patient?
Eyes closed, eyes open.
Okay. And what do you see here?
So when they open their eyes, the alpha disappears.
Okay. Okay, so in this example, tell me where alpha disappears.
C.
Very good. Everybody good with this one? That low amplitude, irregular, unremarkable background activity of falling asleep. And it's slower than your waking rhythm.
Yep.
Everybody good with this guy? I like to call these pre-Ks because they sort of look like Ks, but they're shorter.
Mm-hmm.
And they're more prominent in the central, and they stick out from the background. So here, you can see a little bit of everything. You can see some alpha, you can see some mixed frequency, and there's our little vertex. And here's a summary slide. I think this is a money slide. Everybody good?
Yes.
Mm-hmm.
Mm-hmm.
Okay, everybody good here? Hopefully, otherwise we're in big dog doo-doo. And it's more prominent in the frontal channel. So remember we said the vertex was more prominent in the central? And F4, M1 is the primary scoring thing. And everybody knows that negative is up on EEG. That shouldn't be a
Yeah.
new concept. Okay. And then here's some nice K waves. And should this be scored as a K complex? No, because it's not sleep, right? It's an arousal. K complexes with arousal don't count for N2 scoring. This is a money slide. It's going to show up on your boards.
Mhm.
So that means you woke up. And sometimes, you know, if you have a noise, like a ding, this is what you get in the sleep lab. If you ring a bell, you probably get one of these. Okay? And then this is the difference between K complex and vertexes. And here they are in the same epoch, but they look different, don't they? Faster, different place. Where are they more prominent? Okay, which one is K complex? Anybody?
D as in David.
Good. And, you know, you can always do 1 second and count to see if things are spindles. Everybody good with this?
Yep.
All right, where's our spindles?
C looks like a spindle.
This is actually, in terms of duration, this is like a K with trailing spindles. And D is a little bit slow. And the other, remember, they have to be a certain duration. And, oh, the other thing about this is where are they located? So the amplitude's not defined. The frequency is, they kind of pop from the background. I think A pops the best. And D is a little bit slow. Okay. And here is alpha and spindles in the same epoch. See our spindles? See our alpha? Centrally prominent versus occipital. Here's some slow wave activity. And when you typically look at adults, usually 100 or 125 microvolts is full scale. You want 200 to 250 when you look at kids. And then you see the grid on this. Okay. And how many, you need to measure every slow wave to see if something is N3 sleep?
You
What
need
do you need?
25% of the epic.
You need 6 waves. Yeah.
Yeah.
6 seconds and you're done counting. But this really should be done by a computer, not a human. So here's, you know, finding them all, and you don't have to look for the other ones. Okay, and here's this is a money slide. Something like this will be on your boards, or you'll have to use the data in this slide. Everybody okay about these guys?
Yes.
It doesn't define REM? Okay. There's some sawtooth waves. Okay. This probably was on your in-service exam, right? This
Yeah, we had a
concept?
question about this.
Okay. The eye is like a battery. The retina is negative and then positive. So the way the things move around, it depends on, you know, if you look to the left, where is your cornea in relationship to the left side? Anyway, there will be one question like this where you'll have to figure this out. Everybody good on this one? And knows that eye blinks can be referred in to the EEG?
Yes.
Yes. Okay. And this is kind of I can imagine this will show up in your board exam, this concept of scanning and reading. If you see something like this, somebody is awake and reading. And this is as you're falling off to sleep. And hopefully everybody's seen this. And it's very different than this. Okay, so what's the right answer here?
BNC.
Very good.
Um,
And know that eye movements can, or that EEG can be reflected in the EOGs. Is that shouldn't be a new concept, right?
Right.
Because you can almost stage from your eyes when certain things fall off, especially if you're in slow wave sleep. And this should be review. This shouldn't be new. We see a lot of this. We see twitchies and little transient muscle activity. There's little REM twitchies. And this, I assume that you guys are all good. What's our primary? What's our backup? And you should be good with these. And I think I'm going to stop here. And I think you guys are good about what if you guys feel pretty comfortable about 1 hertz and 8 hertz, etc.
Yes.
Yeah.
Okay. All right, let's do one quiz. What is the frequency of this wave? It's a trick question.
2.5.
Oh, very good. Yeah, because this is about 0.4. So you say 1 divided by 0.4 gives you 2.5. Very good. You can do math. Hey.
I was a physics major, so frequency.
Okay, so this is good for you. But know that you could have multiple frequencies in an epoch. And then we've talked about this one before, and we talked about this one before. Okay, I think I'm going to stop here. Is there anything that's, I think this concept of what the impact of a low pass filter is, this is a money slide, and this is a money slide. Okay, I am going to stop here. Comments, questions?
That was very helpful. Thank you.
All right. So
I
Well,
guess
I see.
I have one
Yes.
quick question that's basically out of all these years, what do you think is the most common thing that you spot almost like instantaneously when you're looking at the sleep study, that you know something about the instrumentation from the tech side was wrong, like BioCal was not done, or like, what's the most common thing that you see?
I think I would probably go back to that, my favorite slide. When we were having a problem, I will check to make sure I'll go back and look to see if the filters were, I mean, you shouldn't have to guess if the filters are right. What is the most common thing that I've seen? We had a lot of problems with the CO2. Sally and I went through a lot, and they actually had a problem with the way they were doing the calibrations. And I think that's gotten resolved. And I think now that all the montages have been standardized, we did have a problem with the wrong filters being assigned to like putting respiratory filters on EEG, or it's gotten better now that the montages are stabilized. Sally, are you still there?
Yes, I'm still there. I'm still here. That was a great overview. And you do have a keen sense and awareness of, so this is very helpful, I think, for me too, and for the boards, and yeah. So sometimes there's really savvy techs who know what they're doing, and other times they need lots of feedback.
Because I find myself in a way that a lot of times when my first instinct I'm trying to look through something that I feel like I'm not seeing, my first instinct to check the gain or to increase the amplitude of a particular channel, but not really to look.
Oh, that's good that you brought that up, because I verify that the amplitudes and the filters are correct before I start. And then from a pattern recognition, if they don't look right, that's how I know. But I would actually, especially when having all those montage problems, but before I start, the answer to your question is, one of the first things I do is I make sure that the amplitudes that I have my pattern recognition for are the ones that are used. And I never, ever touch the EMG.
Okay.
I like that displayed as full scale 50 with minus 25 and plus 25. And I never touch it.
Okay.
Because if you fool with the EMGs, then you can't tell where REM is. So I know what it should be when we start. And if we go back, I don't know if I make sure that one table with all the basic settings is there, that the EEG is the right full scale, and then I go, and then my pattern recognition works. I guess that's what I want to say, because nobody should be changing anything.
Right.
Because if it doesn't look right, there's probably an application problem or an impedance problem.
Okay. Thank you.
So that one table, remember those two tables of what the ASM said? And then I made a second one about which things you should touch and which things you can't touch.
Right.
And what the full range. That's actually a key table for our local lab. And Sally, I can share that with you. And I remember I would put it up in front of everybody's thing, and it's like, don't touch anything. And if it doesn't look right, then something is probably wrong with the application or the filters.
Yep.
Okay. Kelly, anything else you want to?
I think that's good. Good overview. Thank you.
Okay. And guys, do you remember anything from your in-service exam that I didn't cover? That you remember was like a instrumentation thing that you didn't know the answer to?
Wonder if there was artifacts. Sometimes that's were there artifacts on the in-service? I'm wondering.
It's hard to recollect, but I think some of the issue is also that there's only a few questions, so if you missed a couple, the percentile is lower as well. I don't know how many questions particularly we had, but there was a few things that are on here that you covered that were on the exam as well. I don't recall any specific artifacts though.
So maybe that's the problem. There were just a few.
Right. That was
And if you missed them.
Right.
I think it's about 5 or 10% of the exam, the technology and instrumentation. Most of it is covered in the manual, the key things.
Well, I think a lot of the instrumentation that now we're talking about it, and I kind of remember that kind of threw me off. It's like, oh, there are 4 types of HSATs, and what generation or what type is it? Is it okay to do a HST type 2, HST type 4, and those are just like boom. Oh, wait, what type do we even have? Like stuff like that. I at least that's thinking about it. That might be part of the instrumentation questions.
Oh, okay.
That kind of is like, oh.
So, all right. So I didn't cover that. But you know what? The ASM has a position paper about HSATs.
Mm-hmm.
And part of your strategy for preparing for the board is if there is a position paper or a clinical practice guideline, those are money.
Right.
So,
yeah, those are the things I start pulling up to kind of read and review after the training. I'm like, what's the answer?
Yeah, and HSAT is going to be a bigger and bigger part of your practice. Although, this is my wisdom about this. The fewer signals you have, the smarter the interpreting physician needs to be.
Yeah.
Otherwise, garbage in, garbage out. Okay.
Thank you.
Stay safe. Have a great day. And
Can we
I will
talk about clinic?
Oh, yeah, we could do that. Where are we?